Welcome to Innovating Clinical Trials, the podcast designed for clinical research professionals eager to deepen their understanding of clinical trials through concise, insightful segments. Join your hosts, Liam Eves and Ted Trafford, as they uncover the core issues in clinical research, reflect on the industry, and challenge conventional wisdom.
Our guest today is Jill Fikowski, founder and CEO of Changemark Research Plus Evaluation. With a Master of Public Health from UBC and over 20 years in research, Jill works at the crossroads of clinical trials, public health, and community care, with a special focus on substance use and mental health. What makes Jill's perspective truly unique is that she brings not just expertise, but lived experience to this work.
Ted, hello. How are we, sir?
Liam, it's good to see you today. I'm doing actually really well. It's springtime here, but at the same time, it feels like it's still a little bit like winter. So, but we're excited. Good weather's coming.
Good weather. It makes such a difference, doesn't it?
It's amazing.
Makes such a difference. Golf weather is coming. Is about to be upon us. So I'm happy.
Have you been outside yet to actually go golfing? Or are you still doing the indoor thing?
I am going outside. My intent is to go pretty hardcore for summer. So I want to get real down in my handicap, but that's not the way it's playing out, Ted. I'll be honest with you.
Yeah. Wow. Well, excited to have a guest on today. Jill, listen, welcome. Really glad to have you here. Thanks so much for joining us today.
Yeah, thanks for having me. Happy to be here.
Yeah.
I was mentioning to Liam about a conversation we had, and it was just so eye-opening for me, and so just thrilled to have you on the podcast so that others can hear some of the ideas, some of the concepts that you have. And I think a good place to start is to just really dig into you. How did you get into this space? And, what's your origin story?
Mm-hmm. Okay, well, no, thanks so much. And thanks again for having me. So I'll start myself off in a good way and just position myself in this work. So my name is Jill Fikowski, founder and CEO. I use the pronoun she, her, hers. I identify as a cisgender woman and a white settler living on the stolen land of the Musqueam, Squamish, and Tsleil-Waututh nations. The work of Changemark takes place across Turtle Island, what's now known as Canada, from Mi'kmaq territory all the way to Huron-Musqueam. So I am a person with lived experience. So I went through detox and treatment when I was 21 years old. So I have almost 25 years choosing not to use substances. That's how I define my recovery, is choosing not to use substances, because there are people who choose to continue to use substances, and that's their choice, and we just support them the best way we can. That's kind of how we work as a company. I come from a very long line of people with alcoholism and addiction. And actually, I can say all of which who have got help now in different areas through the private treatment center, public treatment centers and whatnot. And I want to just also, mention a couple of things before we dive in here, more definitions, but more in the spirit of breaking the stigma. Sure. I come from a position as a white woman, coming from a middle upper class household who had access to the resources to put me into treatment, to give me transition care, to support me unconditionally. I had family members. And I want to just start by saying that right off the bat, because I've worked with various communities when I've been in research. And I don't want to presume to know their story. And I don't want to presume to know their needs based on how the lens that I'm looking at everything through. So I just want to say that. The second thing is when we talk about substance use, and again, in the spirit of breaking stigma, just for the listeners, there's always, I would encourage folks when they're kind of listening to, these stories, but hearing about people who use substances, to really kind of address their own biases and how they look at people and how they conceptualize people who use substances and people who use drugs. People who use drugs are sitting at the pub. Yeah. People who use drugs are, recreational cannabis smokers. Or they could be people who, took a different turn and had a different journey and ended up in a worse situation. Or maybe people who, had trauma and grew up in that trauma and then ended up in a different situation. So I think people tend to, conceptualize when they hear people who use drugs or the overdose crisis, conceptualize that a certain way. It's just not the case.
Right.
So, my daughter's father passed away from fentanyl poisoning
Uh,
in 2018. I was actually
wow.
working in the same neighborhood that he was living in when he passed away. So when I was on outreach and whatnot, I would see him and kind of report back to his family. And, we had two people here. We had one person over here. That was me, who went through treatment. He went through treatment. He went one way. I went the other way. We both
Right.
came from high SES families with very good upbringings so this is not a situation where, substance use is for, poor people, quote, and make the quote, right? Or people who came from different, this can happen to anybody. So, and he ended up living in, one of the most marginalized neighborhoods in Canada as a result, So just encouraging folks as they're listening to just reconceptualize how we look at substance use as a society and as a community, and address, your biases. And this will lead nicely into researchers addressing their own biases and different levels of stigma. But in terms of how I got into research, well, about a year after I got out of treatment, I got pregnant. And I was on my own. And so I didn't have any education. I didn't have a high school education. I didn't have anything. So I decided to go back to school. And I'm like, well, if I'm on my own, I'm not going to, end up in a worse off situation than I am. So I ended up going back to school. And from the very first year of undergrad, I wanted to dive right into research. And about 3 or 4 years in, I thought to myself, as I started to learn more about public health and people who use drugs and kind of the state of things, I started to think, why is it that I could get access to treatment because my parents had money and other people won't? It's not fair. It's an injustice. And when we're in public health, we look for those injustices and we try to jump in to try and, do what we can. So I did. And I started getting jobs in the field and with different researchers. So all the way from year one undergrad, I've been involved in different research topics, areas, different researchers, different communities. But the real turning point for me was in 2010. I got a job on a highly controversial clinical trial that made the news, made ripples in politics, made ripples with legislation. And it was called the SALOME clinical trial. And it looked at two treatments, injectable diacetylmorphine, which is injectable heroin, and injectable hydromorphone, both opioids to treat chronic and persistent opioid use disorder. So you can imagine the perceptions and what folks were thinking. Well, working in that community and with the community, people use drugs and frontline workers trying to help them and clinicians and healthcare providers trying to help them, it completely changed my life. It completely changed my life because I saw research trying to push legislation, advocate, change policy, elevate participants' voice, hold patient committee and advisory boards. When they were getting picketed at the ports, when the diacetylmorphine was getting shipped in, the investigator was down at the ports trying to push through and advocate for her drug to get through for participants. I had a chance to work with most outstanding people. And I saw this move all the way through the research process, all the way from the ideas and budget phase, making sure that you're properly budgeting in supports and ways to engage from the beginning, all the way to knowledge sharing through the patient advisory committees, all the way through. And then this massive knowledge translation event that wasn't just in the form of peer-reviewed publications or researchers getting to go to conferences. It was bringing together all of these community members who were in the study to roundtable discussions where results were shared with them. And a researcher was sitting at every table with all the participants saying, what could we have done better? How did you do after the study was over? Are you okay? Like, what could we have changed? How could we have supported you better? These conversations were happening. And not only that, those findings were then shared. So there are ways that trying to get a drug to market or trying to get results can live in the same space as community engagement in a really powerful way if people kind of just knew the steps to take around it, and things could be demystified a bit, Yeah.
Yeah.
So,
Wow.
yeah.
So first of all, So sorry for your loss.
Ah.
I appreciate you being, vulnerable today and sharing those things with us. You have an incredible way of viewing things. And I loved when you said, I think you said knowledge translation event.
Mm-hmm.
And I love that concept because even when we put out information about results of a clinical trial, so rarely is it ever translated into something that the participants themselves would understand.
I completely agree with you. Yeah. And and that's another, equity and access piece is who holds the results, who holds the power to this, right? Are you, simply checkboxing saying, okay, we got community input. We gave them this scientific manuscript, asked them to review. They said it was fine for a $30 compensation ticket. And then you let them go, right? Or do you actually care about the population you're trying to get the drug approved for? It's the number one question every researcher should ask themselves is, why are you doing this? Like that study, that trial I was just telling you about, that directly changed policy. That's actually the only trial that I've been involved with that directly changed policy. So it allowed the first, have something in Canada called the Special Access Program. And the Special Access Program gets access to drugs. It's an avenue for researchers or clinicians to get the participant access to the experimental medication when it's shown to benefit them. And so the Special Access Program, diacetylmorphine, the clinicians who are administering the diacetylmorphine, so heroin, trying to get that through Health Canada and the Special Access Program and get folks access to injectable heroin because it was showing to improve their life, right? Not because of the name, because it was being shown to improve their life. This was the first time in history that heroin and diacetylmorphine had been passed through the Special Access Program through Health Canada. It's also diacetylmorphine got a drug identification number as a result of the study for the treatment of opioid use disorder. So this trial was really groundbreaking for a lot of reasons. And so, ask why you're doing this. Are you trying to change policy? There's such hustle right now. I've worked primarily in investigator-initiated studies, right? But I have, in the last 5 years since I started the company, been working with industry sponsors as well. And, bringing a drug to market and the hustle and the pace and the competitiveness and, oh my gosh, we have to get there first, and sacrificing these really important key processes, they're not data points, they're people. Like, it's not just, you're collecting adverse events at every single point. And then at the end of the trial, did you have any adverse events? No? Okay, great. Move on. Close the study. Awesome. We don't have to worry about it anymore. It's not on our radar. It's not our responsibility. But some of these interventions have lasting effects on participants months and years beyond the trial being finished that no one follows up on, right? Like, everyone just gets the data they need and moves on so quickly, right? And I don't know, it's, it all starts with leadership.
What a great start to this podcast interview. Stream our next episode to listen to part 2 of our conversation with Jill. Did something from this episode give you an idea? Do you have a topic you'd like us to discuss on the Innovating Clinical Trials podcast? If so, follow Innovating Clinical Trials on LinkedIn and message us there, or through our website at innovatingclinicaltrials.com.